That's all good.
We'll let the expert mess with the computer. Even though I have informatics, I still know when to stop trying to act like an expert at a computer. We're trying to have some AV ability. We're going to see if it works. I have a video, which is always a risk in a PowerPoint.
Yeah, you should be good.
I think we're able. All right, so nice to meet everybody. I'm Jason Jagodzinski. Work primarily in Oakland with ortho, and happy to go through sort of our orthopedic approach to spina bifida. I do attend the Oakland Spina Bifida Clinic regularly, so you'll see my purple shirt later. All right, so I have no relevant disclosures. I do have a consultant role with orthopediatrics, but it doesn't have anything to do with this, and I have actually yet to receive any money from that consultant, so I'm also open to others. So outline, start pretty much just talking a little bit about general. Dr. Sager did a great job giving a good overview. I'm going to kind of frame it a little bit from my vantage point of an orthopedic surgeon. But then we're going to talk about some spine. Hopefully you can recognize that that spine's a little curved. So there are some deformities that we're going to think about. We're going to talk about hips. Hopefully you recognize some asymmetry. And we'll talk a little bit about that. And then also legs and feet. There's a couple of different things that we think about, we look at with regards to the feet and lower extremities for children with spina bifida. I do like to also go a little bit into sort of the terminology. I think Dr. Sager did a great job already giving a what is, but I think it's important to kind of think about this and also really to highlight that spina bifida occulta doesn't actually, in my mind, register as a neural tube defect. It doesn't have the lower extremity dysfunction. There are some things that we need to think about and be aware of. So as spine surgeons, knowing that there is absent or abnormal, deficient posterior elements of the spine is important, but it actually isn't spina bifida in this theme, right? So like it doesn't have that same context. So usually it's an identified, somebody got a pelvis x-ray, radiologist is astute, identifies that there is an abnormal posterior element, usually around L5 or S1, and they say spina bifida occulta, we get a very quick, easy, but unnecessary referral to orthopedics. So not necessarily something that I worry about. When we think about natural history of myelomeningocele or spina bifida, I think about sort of the function and either a sudden or a slow onset of dysfunction. There, as evidenced in Dr. Sager's talk, there is some expected functional declines as children grow. Their weight may exceed their strength. And I think it's very important to kind of understand, recognize those slow or potentially sudden downturns. I also start to think about shunted or non-shunted hydrocephalus because I do think it has a major factor in recovery, in other sort of ability to tackle some of the things that a patient will need to do in their recovery phase after some of these major operations. I put my age for not walking a little bit lower. I think, if we see the absent, quadriceps function, if we see trunk support that's on the low end, it's going to be difficult to really improve their walking. But I do think that there's a lot of stuff that we can do to help. And the overall sort of natural history is something that we need to move along. And the best predictor of ambulation is really neurological level. So we're going to highlight a little bit more on that shortly. I think Not as a neurosurgeon. I have an approach to a tethered cord that I think is a really important thing that everybody should at least contemplate here. So this is not my world that I actually live in, but I see it probably earlier than the neurosurgeons. So our job is to recognize when and where there could be something else going on so that we can get them connected to Dr. Gupta and the neurosurgeons. So I think about tethered cord, and this is part of the reason for the regular follow-ups, the multidisciplinary clinic settings, is that we can see all of a sudden change. I like the term a copy and paste physical exam, because their neurological function shouldn't change. If all of a sudden you had somebody that had quad function and now all of a sudden they don't, there's something that has changed, and that is not a normal thing. So that's something that you should pause, you should think about. Their bowel or bladder dysfunction has changed, they have new pain, their scoliosis is changing. All of these things are things that you should be recognizing as not normal, and it trigger the assessment, typically an MRI, and then coordination with the neurosurgical teams. Brought up the latex allergy. It's presumption of all is, I think, most of our children's hospital approaches, and so the expectation is just manage the latex allergy so that you're not leading to it. And I've included it on the slide where I also talk about pressure sores from like the skin and exposure risk. This is a patient of mine. I like to think that I do a good job casting. I like to think that our patients all follow our cast recommendations. But the reality is that this is a vulnerable population. The insensitivity, the loss of protective sensation, it can really turn south quickly. So this was a case where I did a heel cord tenotomy to address an equinus contracture, which I did because they were driving their foot down into their AFO, which was leading to the potential for pressure injury. And then a week in a cast, all of a sudden their anterior ankle is looking like this, and then I flip it around and the posterior ankle looks like that. So this is something that you really need to be aware of. It doesn't just happen in a cast. It could happen from a kid whose wheelchair starts to fit funny and their foot is sitting awkwardly on the edge of the foot holding area. I mean, anything can happen. So if you look at a kid's foot and they have spina bifida, take a pause. Remind people to look at their feet. This is kind of like a diabetic adult foot patient. This is something that could really cause major problems in the long term. Infection, cellulitis, osteomyelitis, these are not good problems to have to deal with. So you can really make a big difference by checking and monitoring and reminding both the child from an independent standpoint, but also the family that this is a critical factor that you really have to be mindful. His foot now looks much, much better. I saw him in clinic the other day, and you may notice the color of the shirt. So next, I want to go and highlight a little bit of the functional level. I think that there's some gray in between this, and I will also highlight that levels aren't always clean, right? So you may have motor function in one level, but all of a sudden, sensation is better lower. The patchiness of this diagnosis is something that is unbelievably frustrating at times, I think, because when you think that you have their level figured out, then their sensation is different, or their motor function, maybe their tibialis anterior on one side is firing but not on the other, leading to asymmetric deformities. So I think that it's not always as clean as we like, which can sometimes make it a little bit harder. But I break it down into a couple of different thought processes, and I share each one of them here to be able to better kind of think how I think and maybe figure out how best you can take that home. So breaking this one down, you can see the joint is on the far left, what action it is in the middle, and then the level is on the far right. So the hip has kind of flexion and extension. That's typically going to be, flexion is driven by the higher lumbar levels. Extension is at S1, and you can see actually that's a big difference between where those two happen. So you're going to get a mismatch in functional hip action based off of their level. The AD and abduction, you can see, also has higher lumbar level for adduction strength, lower level for lumbar strength. Similar for the knee, that watershed area is sort of the L5. So below L5, you should have more of a balanced knee strength, where you're getting your flexion strength from your hamstrings. And then the extension is really based off of your L2, 3, 4. And that, again, is a main driver in your ambulatory function. Ankle, again, you can see below. When you break it down into where is your level on the scale, you can also see that different muscle groups, proximal to distal, will also be affected based off of your spinal level, and so you can think about it in that context. Another one then is to go based off of the lowest functioning level, where you are seeing that function will help to determine where their functional level is. So L2, most of the time, this is going to be more of a non-ambulatory. You don't have quadricep strength. You're limited in your hip flexion extension strength potentially as well. And so you can bring sort of your functional level into and have a better understanding of where somebody falls. I have a couple things highlighted here too. So quadriceps function is, again, a major function of gait. So your ability to stand with an extended knee really helps to drive your ability to walk. So that is, again, sort of quadriceps can function to a community ambulator level based off of that. When we get into the lower sacral levels, we really don't see major differences. I think the bowel and bladder function, as you get lower into the sacral levels, becomes an issue. The main thing really does come down to glute function and the function of your ankle plantar flexors. So those are sort of then all broken down into 4 main categories. So this is sort of where I've distilled those last more complex slides into sort of how we generally think. So a thoracic level spina bifida patient, for the most part, not going to have really any effective lower extremity strength. You think about their spine, you think about their sitting balance, but usually you're not looking at ambulation. Hip flexors and adductors are really the differentiator of your high lumbar level. These then we'll get into a couple of slides about where that can really wreak some havoc on what the hip looks like. Your low lumbars, usually these are fairly decent ambulators. They're going to have more lower extremity deformity, some foot abnormalities as well. Sacral level, like I said, again, for the most part, these are fairly functional orthopedic children at least. All right, so prognosis. A lot of kids are going to be ambulating based off of this particular study. But I think that what I really like to think about is, that ambulation potential. Again, your motor level is primary. The strength of your quadriceps is going to be that differentiator. And then you start to think about what may change that over time. So obesity, again, as children are growing, I agree. I wish that the nutrition talk, just with my pace in the multidisciplinary clinic, went faster, but it's such an important thing. And I think that the nutrition, our nutritionist in the Spina Bifida clinic really can help maintain levels of mobility and independence by addressing obesity. Additionally then, monitoring of scoliosis, hip deformity, foot and ankle deformity is really going to make that difference in the long-term ambulatory function. From an orthopedic follow-up care, we fall into the multidisciplinary clinic in a kind of a semi-annual or annual basis. And we like to think about, kind of, again, motor sensory, is it stable or is it changing? Are there orthoses fitting? Do they need anything different to help them with their mobility? Are they developing any pressure points, any deformities? And periodically we'll get some hip and spine x-rays. I don't talk much about fractures in this because I think fractures come into a category that is not necessarily specific to spina bifida, but I really want to pause for 1 second to just tell you that they don't always show the same, right? So the kid doesn't always have tenderness. We already talked about their sensation may not be the same. You could have a kid that caught their foot as they rolled out of their classroom, rotated it, they didn't think anything of it, and it shows up as this big, red, hot, swollen leg. Some people think infection. I think break. Get the x-ray. Quite often you're going to identify a large fracture, and it may be in a delayed state of healing. And honestly, that's quite often how we will see these. You then just have to, again, be aware that the fractures may not present like you think about the Dr. Hill conversation before lunch. So I think that's something that I highlight. Then we want to talk about sort of what are some of the other things. So scoliosis and kyphosis, hip problems, foot and ankle deformities. The slide I was hoping was going to come out a little bit better, but I realize it doesn't, so that's the problem with putting big tables in. But it goes through the more common problems that we fix. Now I get into an even larger table, and I'm like, that wasn't a great idea. So I said, hey, let me help you understand what we're looking at. So top to bottom, we're looking at age. Orthopedics falls right in the middle, and this is the percentage of cases that a child undergoes during their lifespan. So this is just looking at the incidence of surgical management. Neurosurgery comes in right away. They fix the myelomeningocele. They are almost always going to have that surgery in the beginning. Where we fall in is sort of in that middle category. So this is ages sort of 11, 10, 12, 11, 12, 13, 14. Usually growth is about done. We kind of have a good sense of where they're going to be developmentally, where they're going to need some structural support. And this is really, I think about sort of our sweet spot. The beginning ages, I love seeing the little newborns in the Spina Bifida clinic, but usually I'm like, we'll see you soon. All right, I pass off the baton quicker to the kids in the first decade of life especially. So what are our treatment goals? And I think this kind of spans all locations of the body to where we're going to be addressing. Our first thing is maximize ability, right? We want these kids to be as independent as possible. Usually that means maintaining range of motion. So as highlighted before, typically you're going to see an asymmetry of strength depending on the level. So you want to maintain that range of motion as best possible. So that can be through various methods. You want to keep the spine stable. So from a trunk support, they can be more upright. They don't need their arm to help prop themselves in their wheelchair. So we really think a lot about their maintaining ability. Mobility, I think, is also then very key. And it's not always bipedal ambulation. The wheels allow them to be very functional and very independent. And I think that trying to make sure that you're getting the right wheelchair for the right activity, as well as to help get kids to utilize either a wheelchair or other assist device to their full potential. I've got a couple of teenagers that they will not use crutches, but I know their life would be different if they grabbed the crutches and actually ran. So I think that's part of our job, is to try to help with that maintaining ability and maximizing their mobility. And then by monitoring all of these various body systems, we help to prevent deterioration. So let's get into some specific body parts here. So the spine scoliosis happens both in a coronal and in a sagittal plane. So when we look at these two, the coronal plane, the more classic scoliotic curve, but in the sagittal plane, we also see accentuation of the alignment abnormalities. When it gets really severe, we can see a gibbous deformity. This is a hyperkyphotic alignment of the spine that can lead to potential for skin breakdown when sitting in a wheelchair. And then those are some of the things that we will watch and may trigger us to doing a surgical procedure sooner than later. One of the problems, though, is if you saw all of these pictures, where the spine surgery typically is also where the previous neurosurgical scars are. Skin is a much, much harder issue with this. So this is actually sometimes something that we'll call in our plastic surgeon colleagues to help with mobilizing of the soft tissues and to help with closures. There's also a lack of posterior elements. So all of a sudden you're going down to the spine where you would conventionally have a spinous process and lamina. There may be no bony element at all. So there's a more risk to the neurological structures quicker. Deformity correction can come in many different ways. You can use fusion, both posterior and potentially anterior fusion. Sometimes you actually have to remove structural elements altogether and shorten the spine. And again, having your friends available to be able to help with is critical. This is a quick picture actually took from Dr. Diab's book that I think is really, really helpful to better see and identify that gibbous deformity. So if you imagine there's a prominence of the spine through almost a folding over at the that mid-lumbar, and the skin where the previous scar closure is can be very thin, and that could easily rub up against the back of a wheelchair. So that can really quickly deteriorate and lead to some substantial skin issues and infections, as we said before. Thankfully, we don't get horrible kyphosis all that often, so this is a textbook picture that I pulled from when I was a fellow, talking about sort of this kyphectomy, where you will actually remove a major segment of the spine and fuse that spine to be able to get a better, more upright posture. So what are some of those risks? We highlighted them already. Infection is a high risk with this surgery. Between the soft tissue coverage, you also then have the other pressure sores may introduce bacteria into the bloodstream. UTI risk is also ever present in this population. So this is not without caution that you proceed to do a major operative intervention for a young child with scoliosis in spina bifida population. Additionally, the approach, as stated, can be riskier. Sometimes we need to do an anterior fusion because the bone structure just isn't sufficient to get a fusion mass posteriorly. So sometimes you have to involve your vascular surgeons to be able to help with the access to the anterior spine. Enough about spine. I actually don't do that, so that's why I had Dr. Diab give me a lot of information there. So the hips. One thing that I hope everybody recognizes with my little schematic here is this asymmetry. So again, muscle function, muscle strength can really lead to a difference in alignment. But I think that the hips in spina bifida are very complex and a very difficult subset to have to deal with. So I'm going to start off with our video. Let's everybody hope that it works. So we can flex hips, no pain. Internally rotate, externally rotate, hip abduction slightly limited, but no pain. Very good. Thank you. All right, you'll be famous. All right, so we did a little hip exam earlier. Anybody have any idea what his hips are going to look like? What are his hips going to look like? What do you think? I hear dislocated, but he didn't have any pain. I mean, he was very functional, very mobile. You were sticking with dislocated? I see any detractors? They're going to be perfectly normal looking? No, okay. You guys are too good. These are his x-rays. So he is a level 3, 4. He's a wheelchair ambulator. His hips have been dislocated probably his entire life. But you saw him. He was very, very functional. He doesn't have any pain. He doesn't have any difficulties. In fact, these x-rays were from a couple of years prior. I just did surgery for his feet not long ago, and I was like, oh yeah, well your hips are dislocated. I show them the x-ray, and they're like, wait, what? And I was like, yeah, they're dislocated. And he didn't even conceptualize that that's what his hips looked like. But they can be very, very functional from that loss of sensation, that loss of muscle like tightness, spasticity. He was unbelievably functional. And this is, I think, the major problem and confounder in how we approach this problem is that it is absolutely at this middle ground where you could have it look like that, and he has no problem. His muscle imbalance is there, but no big deal. Very common with higher levels, but the sensation is so variable that it's hard to know whether it's going to be a problem. Bilateral dislocations, almost always not a worry. Unilateral, we do sometimes thinking about fixing it because my painful equals painful is a way to say that if they are painful, it is a very painful situation for all. When we get into the unilateral hip dislocations, this kid is L5, so low lumbar, independent ambulator. She's the one that I wish used her crutches because I think it would help her immensely, but she has hip pain, and it sucks because She's very functional. She's an independent ambulator. She's attending college right now. These x-rays you can see have these marker balls. It's because I've had to send her to a total joint surgeon because we don't have a lot of options at this point. Her hip, I started her care well after she was old enough that her hip had been dislocated and it was already showing some deterioration, but you can see this like squaring of that hip. You can see osteophytes, which are signs of arthritis. It's a bad problem. But I have plenty of kids that also have a unilateral hip dislocation that have, again, zero pain. So very difficult to understand how to manage these. I think the most important thing is routine follow-up and monitoring. Getting the hip in a socket early on. Sometimes it could be as much as putting a Pavlik harness on to try to keep a hip if it's in a newborn. Sometimes it's managing with bony surgeries to correct the anatomy. But again, it really does sort of factor into how do they look overall? What other problems are they dealing with? Like, is there other stuff that would prevent the successful management of a hip early on? So difficult problem, not one that I like to see. The things that I also think about with these unilateral dislocations, though, are the functional mobility and the sitting balance. So you can imagine that if you're sitting in a wheelchair and you have one hip that's out, your pelvis tips. Their protective sensation may be missing. So then you all of a sudden have one ischium that is now seeing more stress than the other. So like these are all sort of the things that we think through to manage. But ultimately, I think it comes down to symptomatic management, range of motion. Her motion is still really good. I reviewed again with her hey, we could get you that hip replacement. She's like, I don't want it yet. I like to be a college student. So not a great situation to deal with, but these are the dilemmas that we get. So finally, legs and feet. So when I think about legs and feet, there's a couple of things that I look at. I want the foot to be supple. So it should have motion, and it should be able to be positioned sort of where we want it. It should be stable. So if they're ambulating, you want that foot to be able to support them and to be able to provide some strength. That strength may be bracing, so therefore having some braceable foot. If it is stiff, it's over pulling in one direction and it's leading to pressure sores, those are things that I really worry about. So if it's pulling into inversion, the toe is then rubbing up against the brace and they can't feel it and they get a pressure sore, that's my job to step in and realign either through a tendon transfer, through lengthening of the tendon excisions, sometimes even to just prevent that foot from becoming more contracted to maintain some suppleness. Then I look at ambulation. So I want to maximize strength. Physics really comes in handy. And a lot of these kids lose their physics by their foot splaying outward. So if they're in a bad pes planus, or if in their torsion because of the abnormal rotational strength over time doesn't remodel their normal infant alignment, sometimes they can have really externally or internally rotated limb segments. So the surgery done for this young girl was just a tibial derotational osteotomy, where essentially we took that foot that used to have a very external foot progression angle and we rotated it forward so that now when she stands, her foot has a better lever. So even if her weak gastrocs aren't as strong as they need to be, it at least is working with a better physics to be able to push off. So these are some of the approaches that we have. Sometimes that can be done with just an orthotic, sometimes it's surgical, sometimes it's just providing that assist device. So if they don't have good trunk support, they can use loft strand crutches to be able to provide that support. All things that help to maintain their mobility. So then another surgery that we'll sometimes do, because with the imbalance of the musculature and the strength, there's so many potential imbalances around the foot. One, there's so many joints. Two, there's so many abnormal levels that if you have a functioning tibialis anterior, it's going to pull your foot in, but you don't have your everters, it's not going to have that counterbalance. So sometimes you need to do balancing tendon transfers or potentially potentially, like I said, recessions. The other thing you can see is even just simple toe deformities. So this young man had a hallux valgus interphalangeus, so essentially a bunion that happens more distally, and he was developing pressure points in ingrown toenails because of the alignment of his toe. So we straightened it, placed a screw to just fuse the two joints, and now at least he's not going to develop a pressure sore there. So it doesn't change his ambulatory potential, but it prevents that pressure sore from developing. Orthotics, a lot of orthotics that are out there. This is an example of that ground reaction AFO, and I think this is a really functional brace that can be right for some kids. That helps to, again, to give them a little bit of strength to their quadriceps, which is that sort of watershed option of getting somebody up and standing and ambulating. So the orthotics are critical, and our combination use with the rehab, the MTUs, the orthotists, everybody working together to optimize these. I had just one quick slide to show sort of what braces there are out there and when we use it. This is in the talk, but I would say one of the things that I think is important is the KAFO is not typically used, but when I was in training, I had a mentor that said, always start with more than what you need, because it's much easier to take away a joint from a brace than it is to put one on later, right? So if we're starting with a little bit more involved of a brace, you can usually back down if they don't need that much. And when you get into the HKFO or the RGO, the reciprocating gait orthoses, these are really, really cumbersome. It takes a special patient, a special family, a special therapist to be able to make some of these braces work. So it's not really the panacea of put a brace on them, they're going to walk and they're going to be better. So lots of potential orthoses out there, but we're not going to get into deep there. So quick summary, this is a complex condition. There's many different players in this game. Part of the benefit of the multidisciplinary clinic is that we get to hang out next to each other, bounce ideas off of them. We say, hey, maybe you next, because the tethered cord is more of a concern than their spine right now. Always we're trying to maximize their function. It's not just through the knife and the steel that we can implant. Sometimes it's more the orthotic, sometimes it's the social, sometimes it's a, hey, let's try the brace, let's try the crutches, because that might help. And then supple, stable, and plantigrade. The foot, even if they're not walking, they're still putting their foot down onto the wheelchair platform. That plantar flexion could lead to pressure sore, and again, infection is something we really need to avoid. So, the obligatory question slide is available for you. I think we'll be up for the panel later, so I'll pass along to Dr. Guthrie.